Hi, this is Dr. Akhtarami and today's topic is allergic conjunctivitis. Allergic conjunctivitis, along with other atopic conditions such as hay fever such as also known as seasonal allergic rhinitis. Other atopic conditions are asthma and eczema. They are all atopic conditions which are genetically determined predisposition to hypersensitivity reactions uh, upon exposure to specific environmental antigens. So, the allergic conjunctivitis is a type 1 hypersensitivity reaction, also known as immediate hypersensitivity reaction. It is mediated by degranulation of mast cells in response to action of IgE. There is evidence of an element of type 4 hypersensitivity in at least some forms. Acute allergic conjunctivitis. First of all, acute allergic conjunctivitis. It is very common condition. It's caused by acute conjunctival reaction to environmental allergens. Usually it occurs to pollen. It is typically seen in younger children when they play outside in spring or summer, and they complain of acute itching and watering, and the hallmark is chemosis. Here you can see chemosis in this picture. It is frequently dramatic and worrying to the child and parents, the chemosis. Treatment is not usually required, and the conjunctival swelling settles within hours as the acute increase in vascular permeability resolves. But symptomatic treatment is cool compressions and a single drop of adrenaline 0.1% to reduce extreme chemosis. Next important topic is seasonal and perennial allergic conjunctivitis. These are very common subacute conditions, and they are distinguished from each other by the timing of exacerbations, thought to relate principally to differing stimulating allergens in each. The perennial and seasonal. First of all, the seasonal. The seasonal, also known as hay fever eyes. The seasonal worse during the spring and summer. So the seasonal one is common and worse during the spring and summer, and the seasonal one is more common than perennial. The most frequent allergens are trees, grass pollens. Although specific allergen varies with geographical locations. The perennial type is the symptoms are throughout the year, but worse in the autumn. There is exposure to house dust mites, animal dander, and fungal allergen in autumn. Perennial is less common and there is milder. It is milder than seasonal. Now the symptoms of this both these are there is redness, which may be acute or subacute. There is watering and itching, sneezing, nasal discharge. The signs, the vision is normal. There is conjunctival hyperemia, there is papillary reaction, there is chemosis, lead edema. Investigations are not performed, although conjunctival scraping in severe cases may demonstrate eosinophils, and skin testing for allergens is rarely required. The treatment is artificial tears. They are for mild symptoms, and for more symptoms, the mast cell stabilizers. The mast cell stabilizer they contain sodium chromoglycate and other like nidochromyl sodium, lodoxamide, and these may be used for a few days before exerting maximal effect, but are suitable for long-term use except lodoxamide. Other treatment options are antihistamines. They contain imidaztine or epinestine or leucabastine or pepotestine. Antihistamine can be used for symptomatic exacerbations, and they are effective as mast cell stabilizer. The next is dual-action antihistamine and mast cell stabilizer. They contain iselastine, ketotifen, or olopatadine, and they act rapidly and they are very effective for exacerbations. The next is combined preparation. Combined preparation contain antihistamine and vasoconstrictor, for example entazolene with xylometazoline. The next is non-steroidal anti-inflammatory drugs like diclofenac for symptomatic relief but rarely used. And the next is steroids. The steroids are effective but they are not necessary. And next is oral antihistamines for severe symptoms such as diphenhydramine. They cause drowsiness and they can be useful in aiding sleep. Others are loratadine, have less marked sedative action. So this was all about perennial and seasonal allergic conjunctivitis. Now the vernal keratoconjunctivitis. The pathogenesis of vernal keratoconjunctivitis, it is a recurrent and bilateral disorder. There is IgE and cell-mediated immune mechanism, and it affects boys and from 5 years and onwards. In 95% cases, there is remissions. And there the remaining 5% develop atopic keratoconjunctivitis. It is rare in temperate regions but common in warm, dry climates such as Mediterranean, Sub-Sahara Africa and Middle East. In temperate region, 90% of patients have other atopic conditions such as asthma, eczema. So two-thirds have a family history of atopy. The VKC they occurs on seasonal basis, and the peak incidence is late spring and summer, although there may be mild perennial symptoms. It is divided into palpebral and limbal and mixed. The palpebral affects the upper tarsal conjunctiva associated with corneal disease, and there is because close application between the conjunctiva and corneal epithelium. The limbal affects black and Hessians. The mixed has features of both. Now the diagnosis is clinical. Investigations are not required. Eosinophils are abundant in scraping. The symptoms are the same as itching and lacrimation, photophobia, foreign body sensation, burning, thick mucoid discharge, increased blinking is common. The palpebral disease, there is conjunctival hyperemia, an early disease, and diffuse velvety papillary hypertrophy on the superior tarsal plate. Here you can see macropapilla. The macropapilla are less than 1 millimeter in size. And there is focal inflammatory infiltrates. Here you can see. There is a flat top polygonal appearance. They are reminiscent of cobblestones. They may be focal or diffuse. There is whitish inflammatory infiltrates in intense disease. Then it is progress to giant papillae. The giant papillae you can see here. The macropapillae here, it is diffuse infiltrate, and there is focal here. In this picture they see there is a giant papillae. The giant papillae they are more than 1 mm, and there is adjacent smaller lesions amalgamate when dividing septa rupture. There is mucus deposition between giant papillae, and also there is decreased disease activity by milder conjunctival injection and decreased mucus production. Then the limbal disease, there is now the limbal disease, there is gelatinous limbal conjunctival papillae, may be associated with transient apically located white cellular collection called Horner-Trontas dots. Here you can see Horner-Trontas dots. They are white cellular collections. In tropical region, limbal disease may be severe. The next sign is keratopathy. Keratopathy, here you can see, is more frequent. Keratopathy is more frequent in palpebral disease and may take the following forms. keratopathy, there is superior punctate epithelial erosions associated with layers of mucus on the superior cornea. Keratopathy there is superior punctate epithelial erosions. They are associated with layers of mucus on the superior cornea. Here you can see superior punctate epithelial erosions with layers of mucus on the superior cornea. There may be epithelial macroerosions by combination of epithelial toxicity from inflammatory mediators and direct mechanical effect from papillae. Here you can see the plaques and shield ulcers. They develop in palpebral and Meigs disease when the exposed Bowman membrane becomes coated with mucus and calcium phosphate, which leads to inadequate wetting, delayed reepithelialization. This is serious and urgent attention to prevent secondary bacterial infection. Subepithelial scars are gray, oval, and affect vision. Here you can see pseudogerontoxon. Pseudogerontoxon can develop in recurrent limbal disease. There is a paralimbal band of superficial scarring. They resemble arcus sinalis, adjacent to a previously inflamed segment of the limbus. Vascularization does not tend to be prominent. Some peripheral superficial vessel in growth is common, especially superiorly. Keratoconus and other forms of corneal ectasia are more common in VKC. Keratoconus thought to be at least partly due to persistent eye rubbing. So keratoconus is very important. Herpes simplex keratitis is also more common than average, less so than in atopic. In atopic it is more. It can be aggressive and is occasionally bilateral herpes simplex keratitis. The eyelid disease is mild in contrast to atopic keratoconjunctivitis. Now the atopic keratoconjunctivitis. It is a rare bilateral disease, develops in adulthood between 30 to 50 years, following a long history of atopic dermatitis, also known as eczema. Asthma is also extremely common in these patients. In 5%, there is childhood VKC. There is little or no gender preponderance. There is chronic and unremitting. AKC is chronic and unremitting, and there is low expectation of eventual resolution. And there is associated significant visual morbidity. The VKC is frequently seasonal and worse in the spring, while the AKC is perennial and worse in the winter. Parents are sensitive to a wide range of airborne environmental allergens. Now the diagnosis, the distinction between these two, the AKC and the VKC, it can be made clinically. The eosinophils are less common in VKC. In AKC, the symptoms are similar, but there is more severe and unremitting in AKC. The eyelids, as you can see, there are skin changes in AKC and there are eczematite, erythema, dryness, scaling and thickening, sometimes with disruption to epidermal integrity such as fissuring, scratches, also excoriation. There is intense itching. There is chronic staphylococcal blepharitis, madarosis. There is keratinization of the lid margin. There is a Hartoghi sign, which is absence of the lateral portion of the eyebrow. Denny Morgan folds, which are the lid skin folds caused by persistent rubbing is tightening up the facial skin, may cause lower lid ectropion and epipora. Ptosis is uncommon. Now about the conjunctiva, conjunctival environment is preferentially inferior palpebral, whereas in VKC it is worse superiorly. There is discharge more watery than the stringy. In VKC it is stringy, while here it is watery. Hyperemia, chemosis is during active inflammation. Papillae, they are initially smaller than in VKC, although larger medieval plateau. There is diffuse conjunctival infiltration and scarring. Here you can see diffuse conjunctival infiltration and scarring may give whitish featureless appearance. And here you can see the cicatricial changes can lead to moderate semblepron, farnesial shortening, keratinization of the caruncle. Here you can see keratinization of the caruncle. So limbal involvement similar to that of limbal VKC can be seen, including Horner, Tronta's dots. Now keratopathy. There is punctate epithelial erosions on the inferior third of the cornea. Let me be marked. Here you can see the peripheral vascularization and stromal scarring. Here you can see the persistent epithelial defects. There is focal thinning, and it may lead to perforation with dysmetocele. And here you can see the plaque formation. Also the predisposition to secondary bacterial and fungal infection and aggressive herpes simplex keratitis. The keratoconus is also common, and as with VKC may be secondary to chronic ocular rubbing. The cataract, there is presenile shield-like anterior posterior subcapsular cataracts and exacerbated by long-term steroid therapy, and high lid margin carriage of step aureus. The cataract surgeries carries increased risk of endophthalmitis. The retinal detachment is more common than in the general population following cataract surgery. Now the treatment of VKC and AKC. The management of VKC does not differ from that of AKC, although the AKC is less responsive and require more intensive and prolonged treatment. The general measures are allergen avoidance, that is the allergen patch testing is sometimes useful. Cool compress, lid hygiene for blepharitis, moisturizing cream E45 for dry fissure skin, bandage, contact lens to aid healing of persistent epithelial defects. Now the local treatment, mast cell stabilizers such as sodium chromoglycate to reduce the frequency of acute exacerbations and the need for steroids. Several days to weeks of treatment are needed. Topical antihistamine, they when used in isolation are about as effective as mast cell stabilizers. Combined antihistamine with vasoconstrictor, combined action of antihistamine mast cell stabilizer such as olopatadine have a relatively rapid onset of action. NSAIDs such as ketorolac may improve comfort by blocking non-histamine mediators. Topical steroids such as fluorometholone 0.1%, remaxilone 1%, prednisolone 0.5%, loteprednol etabonate 0.2% or 0.5%. They are used for severe exacerbations of conjunctivitis and significant keratopathy. Reducing conjunctival activity generally leads to corneal improvement. They are usually prescribed in short but intensive 2-hourly initially courses aiming for prompt tapering. Although the risk of elevation of intraocular pressure is low. The stronger preparations such as prednisolone 1% can be used, but they carry risk of steroid-induced glaucoma. Shield ulcers are often refractory to topical steroid treatment. Steroid ointments may be used to treat the eyelids in AKC. Duration of treatment should be minimized. Antibiotics may be used in severe keratopathy. Acetylcysteine is a mucolytic agent to dissolve mucous filaments. Immunomodulators such as cyclosporine, if steroids are ineffective, inadequate, or poorly tolerated, are steroid sparing agents. Calcineurin inhibitors, alternative to steroids, such as tacrolimus 0.03% ointment, instillation into the fornix, effective in modulating conjunctival inflammation. Tacrolimus 0.1% ointment, when applied topically in patients with shield ulcers and corneal epitheliopathy, they can be used without topical steroid. Supratorsal steroid injections may be considered in severe palpebral disease. Injection is given to the conjunctival surface of the anesthetized averted upper eyelid. 0.1 ml of beta-methasone sodium phosphate, dexamethasone or triamcinolone is given. So the important thing is topical steroids should not be used long term without monitoring of IOP. Systemic treatments such as oral antihistamines, it may help itching, promote sleep, nocturnal eye rubbing, reduce nocturnal eye rubbing. Antibiotics, doxycycline, azithromycin to reduce blepharitis, immunosuppressive agents, steroids, cyclosporines, tacrolimus, azathioprine, relatively low dose in AKC and responsive to other measures. Other treatments include aspirin in VKC, but avoid it in children due to Reye syndrome. Surgery, superficial keratectomy to remove plaque, deprived shield ulcer. Medical treatment must be maintained until the cornea has reepithelialized. Excimer laser phototherapeutic keratectomy, surface maintenance restoration surgery such as AMT, lamellar keratoplasty, eyelid procedures, botulinum toxin induced ptosis, lateral tarsorrhaphy for severe persistent epithelial defects or ulceration. Gluing may be appropriate for focal punch-out corneal perforations. Thank you so much.